CME on organized by the Department of Clinical Microbiology and Infectious Diseases, All India Institute of Medical Sciences, Rajkot. We have an exciting program lined up with expert speakers who have proven expertise in the field of hepatitis in general and viral hepatitis in particular. The organizing committee extends a very warm welcome to all the speakers for CME. On this World Hepatitis Day, that is on 28 July 2025, we stand united in the global fight against hepatitis. This day reminds us that despite being preventable and treatable, hepatitis continues to claim lives due to lack of awareness and timely diagnosis. Together, through strong public health efforts and collaboration, we can move closer to the vision of hepatitis-free world. So over the next 3 hours, we have experts from the field deliberating on the current status of viral hepatitis, the progress and achievements in our fight against the disease, and gaps and needs in our efforts to eliminate the disease as a public health concern. Delegates may pose their queries in the chat box. We will try to address them at the end of the session. In case we are unable to take your questions due to paucity of time, we will surely revert back via email. So without further ado, I request Dr. Ashwini Agarwal to deliver the opening address on mapping the burden of hepatitis B and C in women of childbearing age in Gujarat. Sir is an alumnus of the prestigious Armed Forces Medical College, Pune. He has served in the army for more than 25 years, during which he was posted in leading tertiary care hospitals and teaching institutes of the armed forces. He was professor in microbiology at his alma mater before he decided to hang up his uniform. Dr. Agarwal is a passionate teacher and diligent researcher. Currently, Sir is working as Dean Research and Professor and Head, Department of Clinical Microbiology and Infectious Diseases at AIIMS Rajkot. Sir is a Principal Investigator of VRDL and VSL-3. Over to you, Sir, Dr. Ashwini Agarwal.
Thank you, Dr. Bhumika. Am I audible?
Yes. Yes, you are.
Okay. Thank you. Thank you for joining. This is our third endeavor on the World Hepatitis Day. We are organizing this international CME for the third time, and this time we are doing it under the aegis of VRDL, that is Viral Research and Diagnostic Laboratory of ICMR. This laboratory was inaugurated at our institute on 10th August last year by Honorable Shri J.P. Nadda ji. And I take this opportunity to pay tribute to the man who is standing next to Shri J.P. Nadda ji. That is Shri Vijay Bhai Rupani, who was former Chief Minister of Gujarat, and he recently lost his life in the Air India crash in Ahmedabad. He was the key person who brought this AIIMS to Rajkot, and he was also driving force for our VRDL. He came for inauguration also. So we pay our homage to him. I also pay tribute to this man of great repute, extraordinary man, whose birthday we celebrate every day as World Hepatitis Day, the Nobel laureate, who in 1967 discovered the hepatitis B virus. He also developed the blood test to detect hepatitis B virus, and then he went on to invent hepatitis B vaccine. So today we have eminent speaker. I welcome you all. We have with us Professor Dr. Priya Ibrahim, who is former director of NIV and presently working as senior professor in CMC Vellore. She will be deliberating on hepatitis A in India. India aims to eliminate hepatitis by 2030. Professor Dr. Ekta Gupta is into it, and she has become integral part of our CMEs. She will be talking on the roadmap for hepatitis B and C, management by 2030. And lastly, we have got Professor Rahul Thodapkar, who is a professor and head at JPMER Pondicherry. Sir will be talking on the theme of our today's CME, that is protecting two lives, how navigating hepatitis B in pregnancy. What are the current practices and updates in India? To set the ball rolling, I will be presenting this small study. In fact, the first study we did from our VRDL of mapping the burden of hepatitis B and C in women of childbearing age in Gujarat. So this was the study, and I will tell how this study formulated, and we went on and finished it within a period of 6 months. Today, if we want to eliminate hepatitis, if we think of eliminating hepatitis B by 2030, our main focus is on hepatitis B and C. These are the two viruses which account for 96% of mortality, and they are the one which needs to be controlled. They are major public health problem, and because they go on to develop chronic hepatitis, and both of them are transmitted by parental mode of transmission. Luckily for us, we have got certain effective interventions available for both of them. For hepatitis B virus, we have a very, very effective vaccine. There is no virological cure at present, but drugs are available which can control viral replication. So any patient with HBV may require long-term monitoring and treatment. For HCV, there is no vaccine available as such, but excellent drugs, direct-acting antiviral medicines are available, which can cure more than 95% of patients. So we have got interventions for both of them. As far as hepatitis B is concerned, most of the global burden of chronic hepatitis B is now attributed to vertical transmission and some to horizontal transmission. Vertical transmission is that is mother to child. Any pregnant woman who is a chronic HBV patient, and if is also happens to be HBe AG positive or has high viral load, have more than 90% likelihood for mother to child transmission. The second mode of horizontal transmission is by exposure to infected blood, that is from an infected child or adult to an uninfected child, which generally occurs during first year of life. So these are the two main modes which are still a problem, because we have started screening the blood, we have started using disposable syringes and other medical devices, but these two needs to be addressed. As soon as a individual acquires hepatitis B infection, the more is the chance of becoming it chronic. If it is in neonatal age, then it is more than 90% chance. In children of 1 to 4 years, it is around 30%. And if an adult acquires an infection, then it is less than 5%. So more than infected infants can go on to develop chronic infection, and out of which around 5 to 10% may develop liver carcinoma, and around 20 to 30% go on to develop cirrhosis, which has its sequelae like decompensated. It can become decompensated and may also lead to hepatocellular carcinoma and finally death. So we need to focus on the women of childbearing age, because this group is central to interrupting vertical transmission of hepatitis. And most of these women are unaware of their status because of lack of symptoms. So they are the hidden burden of hepatitis, and early diagnosis and timely intervention can prevent mother to child transmission and reduce complication. So it is recommended that all mothers should be screened for HBsAg during antenatal care screening, and if they are found positive, then maternal antiviral prophylaxis should be given if viral load is high or HBeAg is positive. So Dr. Rahul will be deliberating on it in detail, and along with it, infant HBIg, hepatitis B immunoglobulin prophylaxis should be given shortly after birth. Vaccination is the main modality to reduce the transmission, and now it is recommended that timely birth dose and early childhood vaccination should be given 3 doses during 6, 8, and 14 weeks, and to adults also. Vaccine has shown that since the time it has been introduced in early 2000, it has greatly impacted the seroprevalence. It has brought it down, and it has also great impact on incidence of hepatocellular carcinoma. So vaccine is very effective intervention if implemented properly. However, we are still far off our vaccination target. As per the WHO 2024 World Hepatitis Day report, percentage coverage of birth dose is 63% and 3 dose in infant is 93%. However, the target for 1920 was 90% for the former and 95% for the later. So we are still away from our target. Hepatitis C is also a blood-borne virus, which is transmitted through blood and sometimes also through sexual practices. Perinatal transmission is less common. It is not like hepatitis B, it is around 5 to 15%, but higher rates are associated with high maternal serum viral load. If there is concomitant HIV infection, prolonged or difficult delivery, or invasive fetal monitoring during delivery. If a patient acquires HCV infection, large number of them, around 2/3 of them, may become chronic hepatitis, and they may further progress to cirrhosis and develop sequelae later on. HCV's importance in childbearing age is that if the status is known, then that lady should be treated as soon as possible before she is considering pregnancy. If once she gets pregnant, then there is no data available on the use of pan-genotypic regime during pregnancy. Also, there are many drugs which are contraindicated during pregnancy. So we generally do not recommend treatment during pregnancy. However, pregnancy itself does not appear to negatively affect the chronic HCV infection. Higher incidence of what we can see in pregnancy is higher incidence of intrahepatic cholestatic of pregnancy, and if this syndrome is there, that mother should be followed. HCV infection in pregnancy is associated with increased rate of adverse outcome, both in maternal and neonatal. In maternal, it can lead to preeclampsia, more chances of cesarean section, hemorrhagic complication and death. And in neonates, preterm delivery, low birth weight, and neonatal death. So these patients, if they are found HCV positive, they require referral to a high-risk obstetric specialist care unit for monitoring and treatment. So NVHCP, as we all know, National Viral Hepatitis Control Program, was launched in 2019, and which provides screening, diagnosis, counseling service, and algorithm-based treatment of chronic hepatitis B and C free of cost to all, with aim to eliminate hepatitis C by 2030 and reduction in the infected population morbidity and mortality associated with both B and C. So, but this program has faced lots of challenges since its inception, and one of the major challenge was limited availability of reliable national and state epidemiological data, which was crucial in making any policy, micro-level planning, or targeted intervention. And the second challenge was low access to preventive testing and treatment service. So with this background in mind, we planned this study of mapping the burden of hepatitis B and C in women of childbearing age in Gujarat. And to be very honest, the idea came to us during our last year's CME when Dr. Ekta presented her work in Delhi state, when they used this hub and spoke model to trace HCV patients in Delhi, and further they went on to diagnose and treat them. So we thought of going on similar lines for both B and C first do mapping, and then we can go further for treatment also. So that was the time we were planning another study for determining prevalence and other determinants of anemia in pregnant women and adolescent girls in Gujarat. This study was a comprehensive cross-sectional study which was to be done across 10 districts of Gujarat. So Gujarat, if you know, is divided mainly into three parts. One is the mainland China, mainland Gujarat, which lies on Delhi, Bombay main route, which can be divided into three parts: North Gujarat, Central Gujarat, and Southern Gujarat, with the major cities like Ahmedabad, Vadodara, and Surat lying in it. So this is the area which has got comparatively good medical facilities. The second area is the Saurashtra region, the center of which Rajkot is located, and that was the main reason why this Saurashtra was chosen for as site for AIIMS. And the third region is the Kutch region, which has mainly desert type of environment. There is no government medical college there. So this is the area which is difficult to reach. So we planned this study in covering the north, central, southern Gujarat and Saurashtra region, 2 to 3 districts from each representing, and from each district at least 500 participants, both pregnant and adolescent, 250 each. So we were doing this, planned this study for determining the determinants of anemia, but we added this secondary objective of estimating the prevalence of hepatitis B and C also to it. So we had a study population of 5620 women of reproductive age, 15 to 45 years, of which 2,815 were adolescent girls and 2,800 pregnant women. So informed consent was taken.
Uh, just wait. Maybe AIIMS Rajkot will join again.
Okay, I'm sorry. Power breakout. I hope I am audible.
Yes, sir.
Yes, you are.
Yes,
Yes,
sir.
you are.
So we had 2,815 adolescent girls from 30% each from urban area and tribal area, and 40% from the rural area. And the large number of girls, around 60% of them were more than 15 years of age. Amongst the pregnant women, we had representation from rural and urban 30% each, and tribal 40%. As far as their pregnancy trimester is concerned, 16% were in first trimester, 43% in second trimester, and around 40% in third trimester. On my right, we can see the age group. So the maximum was 20 to 24 years. And this map shows different districts which we targeted and the results we got. As you can see from the North Gujarat, the prevalence was comparatively low. It was for HbSAg 0.26 and for HCV also 0.26. For Central Gujarat, 0.68 and 0.25. And for southern Gujarat, this is the area where large tribal population is there. We had a significant HCV seropositivity of around 0.454%. But HbSAg seropositivity was maximum in Saurashtra region, which goes up to 1.38%. So this was the result in nutshell, what we got first on the ELISA. So out of total 5620 samples, 44 were seropositive for HbSAg. So state prevalence come to around 0.78% in women of childbearing age, of which 10 were adolescent and 34 were pregnant females. Maximum number of this patient, around 50% in case of adolescent and around 40% in case of pregnant female, were from scheduled caste and scheduled tribe, followed by OBC. There was also population heterogeneity. The prevalence increased with age. It was higher in rural area and tribal area and highest amongst SC/ST population. Out of 34, only 3 of the pregnant women, that is only 8.8%, were aware of their HbSAg positive status. So 91% of them didn't knew about their status, and out of which 18, that is 53% of them had pregnancy earlier. So there is need to check their previous pregnancy outcomes also, their family also. 11 of them were identified as high-risk pregnancies for various reasons, but none because of hepatitis. And in these 34 patients, 10 had high viral load. So these are the ideal candidate first to treat with antiviral drugs and then to give hepatitis B immunoglobulin to child after birth. Out of 5620, 19 were found to be HCV positive. So state seroprevalence come to be 0.34, of which 6 were adolescent and 13 were pregnant. None of the women was aware of their HCV positive status. And again, we saw more prevalence in scheduled caste and scheduled tribe, followed by OBC. 6 of the females had pregnancy earlier, but we don't know about the outcome. So coming to the discussion, studies across India have reported varying prevalence of hepatitis B virus in different geographical areas, communities, and social group. Some studies have shown that prevalence is as high as 60% in some Jarwa tribes of Andaman and Nicobar Island, and as low as 0.2% among blood donors. As per WHO Global Report of 2024, HBS seroprevalence in India is estimated between 3 to 4.2%. CDC also put India in low intermediate category with estimated prevalence of 2 to 4.9%. However, in our study, we found the seroprevalence in women of childbearing age, we were limited to women of childbearing age, to be 0.78%. Our findings are similar to the data of National Family Health Survey 4, which was done from 2015 onwards and published in 2021. So in this, it was their aim was to detect HIV, but they later extended it to detect HbSAg and HCV also. As per this, national seroprevalence was found to be 0.95 and Gujarat seroprevalence was 1.2%. So probably if we include more further age groups, we can go up to 1.2, but our findings are more nearer to this NFHS 4 survey. So population heterogeneity as reported in NFHS 4 surveys was also noted in our study. The higher seroprevalence was in rural areas, in scheduled tribes, and among high-risk sexual intercourse individuals. Similarly, seroprevalence of hepatitis C estimated burden is again kind of wide range in different studies. ranging from 0.19 to 53.7%. But WHO Global Report estimate it to be around 0.5%. And in our study, seroprevalence was found to be 0.34%. Again, this is very close to NFHS 4 survey, in which national seroprevalence was estimated to be around 0.32%. But it is higher than the estimated value for Gujarat in NFHS 4, which was 0.19%. In NFHS 4 also, they reported heterogeneity in data. Seroprevalence was higher in male, increases with age, higher in urban areas, highest among scheduled tribe, and increased seroprevalence was observed among higher risk sexual intercourse individuals. So if we see these numbers, that is HbSAg 44 positive and anti-HCV 19 positive out of 5620, these numbers may appear small, but they have significant clinical and public health implications. Most of these women, in fact, more than 90% for hepatitis B and all for hepatitis C were unaware of the status. Each positive case, if pregnant or planning pregnancy, carries a risk of vertical transmission, and it is more so in case of hepatitis B. And if we miss these cases, each undetected case represent a missed opportunity for prevention. 12 HbSAg positive women had viral load, of which 10 were pregnant. And these are the patients who needs to be treated with maternal antiviral prophylaxis and infant HbIg prophylaxis after birth. Otherwise, they have more than 90% likelihood of mother-to-child transmission. So our finding underscores the urgency of integrating routine hepatitis screening in reproductive health scheme, because these reproductive health scheme like Anemia Mukt Bharat and reproductive maternal and child health and adult in neonates, child and adults program, they are very well established up to the PHC level. But we observed that detecting hepatitis B and hepatitis C, even in antenatal care, is not so well implemented when we talk about the peripheral centers. And whenever they are detected, timely referral to higher center for management and follow-up is required. So our study highlights certain gaps in current maternal health program. Hepatitis B virus testing is not uniformly implemented across antenatal checkup. HCV is almost never included in antenatal screening in peripheral setup. And even if the test is done, it comes positive, there is no post-test counseling and follow-up for the patient. HbIg availability is sporadic and most probably not available in peripheral centers. Patient have to go to higher centers, and the healthcare providers giving the consultation there, they are unaware of national hepatitis management guidelines. So what is required is alignment with NVHCP and WHO goals. NVHCP recommends universal hepatitis B antigen screening testing in pregnancy, and the program focuses not only on diagnosis but also on management and further elimination. WHO has introduced this triple elimination strategy, which is targeting HIV, syphilis, and HBV in pregnancy. So there is a need to scale up plans for government of Gujarat hepatitis program and align these programs with NVHCP and WHO goals. So based on our findings, we give certain recommendation, including clinical recommendation, including all patients, all pregnant females, universal HbSAg testing should be done during first antenatal care visit. And if anybody is found positive, reflex viral load testing to be done. Timely administration of HBV birth dose vaccine should be done within 24 hours. And this is crucial because vaccine is the most effective intervention available to us. Unlike a hepatitis B, we do not have any vaccine for HCV, making early detection and linkage to care even more critical. Anti-HCV testing is in high-risk population and endemic district is required, like in tribal areas, the areas with more population of SC, ST, and postnatal referral and follow-up of all hepatitis positive mothers. We are going to further give certain policy level recommendation. In fact, we have a meeting scheduled with Principal Secretary here to present these findings. And we would be recommending including hepatitis screening in standard antenatal care testing protocols, integrate anemia with maternal nutritional program, train the peripheral workers, ASHA worker, ANM workers on hepatitis awareness and referrals. Awareness of national hepatitis management guidelines amongst healthcare providers is required. Doctors are sitting there, but they are not aware, and that's why we do this meeting every year to establish fast-track referral and treatment linkage pathways and ensure that HBIG and vaccine stock is available and peripheral setups. Future direction would be to conduct HBV DNA and HCV RNA testing. HCV RNA testing is important because by rapid test or ELISA test, we miss a large number of cases which may otherwise be carrying the virus. Genotyping studies can be planned to find the circulating strains in Gujarat. Longitudinal follow-up of infected mother and their children to see the effect. A cost-effective analysis can be planned of universal versus risk-based hepatitis screening and explore impact of awareness program at community level. So this was the study, and these are the recommendations which we are going to make on the basis of our study. Our acknowledgement to SHSRC, that is a State Health System Resource Center, who planned their study for anemia, but gave us permission to extend it to include hepatitis. The collaborating district administration and health department, whose role was crucial in patient recruitment. We went to the interior of the villages. The study was not done in a tertiary or a secondary care center. We went to the peripheral health center and beyond, even up to their home, to collect the sample. We are grateful to the all women who have participated in the study, and lastly to the project investigators, staff, and the VRDL staff and the technical team. So this is our small VRDL team by which we have started the work in Gujarat, and we hope that we will come up with certain good result in near future. Thank you very much. Enjoy.
Thank you, sir, for this wonderful deliberation. Our next speaker needs no introduction. Ladies and gentlemen, it's an honor to introduce our esteemed speaker, Professor Dr. Priya Abraham. Ma'am is a distinguished virologist with an illustrious career in the field of clinical virology. She has served as a director of the NIV Pune, where she led groundbreaking research and contributed significantly to the understanding and management of viral diseases in India. Dr. Abraham was involved in the nation's first evaluation of the indigenous hepatitis B vaccine in the late 1990s, after which India became self-reliant for this vaccine. Dr. Abraham was at the forefront of India's fight against COVID-19. As a director of NIV, she was instrumental in developing India's own homegrown vaccine against COVID-19, a remarkable achievement that has also been depicted in the movie Vaccine War. Currently, ma'am is a senior professor in the Department of Clinical Virology at the Christian Medical College, Vellore, where she continues to inspire and mentor the next generation of virologists. So today, we are privileged to have her share her insights on the hepatitis A in India, changing epidemiology, clinical challenges, and the way forward. Over to you, ma'am, Dr. Priya Abraham.
Thank you very much. At the outset, I would like to thank Professor Dr. Colonel Ashwini Agarwal, Dr. Padi, and the rest of the faculty of this department. First of all, I want to congratulate you on your excellent study, piggybacking the study of anemia in the women in Gujarat. It's brought out some very important findings. and the further steps forward, Dr. Agarwal has very wonderfully outlined. So that sets a very good tune for today's meeting. May I now share my slides?
Yes, ma'am. ये करो बंद कर दिया मैंने.
Are they visible now?
Yes, ma'am, they are visible.
Okay. So good afternoon to you once again. And my mandate was to speak to you about hepatitis A in India, the changing epidemiology, the current clinical challenges, and the way forward. So in the past, we have always taken hepatitis A infection to be a mild, self-limiting infection affecting young children, leading to mild or asymptomatic infection in children. And we considered the children of 10 years to be mostly exposed. By 10 years, at least 90% of them would have been exposed to this virus, leading to very little disease in adults, because a lot of the exposure happened in early childhood. That was the epidemiological picture about 20 years ago. And therefore, at that time, the importance of other interventions to such as vaccination was not taken as a priority for a country such as ours that has many concomitant health challenges. But today, if we look at what the data tells us, India continues to experience definitely a high age standardized incidence burden of greater than 2,000 for every 100,000 population. But what we are noticing is that there is an increasingly visible clinical burden. As I said earlier, it was mostly affecting young people, young children, where the infection was asymptomatic or mildly symptomatic. But now we are seeing a more apparent clinical burden with very severe symptoms. And what we see today in our country is that we have heterogeneous pockets of highly susceptible people who have not been exposed to the virus, and those who have been exposed, typically maybe more affluent people in our population being susceptible, and those coming from lower socioeconomic settings being exposed early in life. So this is a heterogeneous picture. We are a country in transition. And as a result of that, in the clinical setting, we are seeing increased symptomatology in young children as compared to the past, where children were hardly symptomatic when they picked up the infection in the first decade. Increased mortality in adolescents and young adults, and increased rates of severe infection among adults. And we have seen in the past 3-4 years, several outbreaks along the length and breadth of our country, where adolescents and young adults have presented with very severe hepatitis A virus infection. What are the causes for the change in epidemiology we are seeing in some parts of our country? Improved sanitation, better hygiene, maybe improved socioeconomic status for some parts of our country, more access to safe drinking water. We see almost everybody carries around bottled water, and people are aware of sourcing water from sources where the water is likely to be safe for drinking. And more recently, there has been one possible suggestion that after exposure to COVID-19, which had generated a very hyperinflammatory response, that could have also affected the liver tissue. Therefore, subsequent infection, which with a hepatotropic virus such as hepatitis A, may trigger serious inflammatory response in the liver. This is one possible explanation. But even otherwise, epidemiologically, we know some populations are upward bound, and therefore with awareness, better amenities, better access to safe drinking water, better access to toilets, living in pakka houses rather than mud houses with proper piped water supply. This epidemiology is beginning to change in our country. Now, I just actually put up a comparison of two studies. One published by Dr. Acharya, Professor Acharya from AIIMS, more than 2 decades ago, and present data which we completed in 2024, between 2015 to 2024. So literally there are at least almost 2 decades separating the analysis of data from our population. So you can see in your extreme left column, the age group in years for the study done in 2003, somewhat matching age group in the third column for the study completed in 2024, and look at the difference in seropositivity. Likewise, if you go to the next age group, again, somewhat comparable, there is almost half the seropositivity to hepatitis A in the subsequent study that got completed in 2024. And the next age group as well, you can see a remarkable difference. This is the cumulative seropositivity in these age groups, suggesting cumulative exposure. And you can see that earlier on in our country, exposure was very rampant, very early in life, in young children, whereas now children within the first decade are not that much exposed to the virus. When they get on to the second decade, somewhat little more exposed. And before they reach adulthood, they are not fully exposed, as a result of which we find young adults and older adults also becoming vulnerable to this infection. And we all know the older we are when we pick up hepatitis A virus infection, the more symptomatic we will be. Now, this is again data coming from this center in CMC Vellore, and this gives you the out of the positives, 2002 positives that we got spanning these 10 years. We looked at the percentage positivity in the different age groups. And you can see, of course, in infants, you don't expect much because they will have the mother's antibodies that they have got that was crossed over to them in the placenta. But if you look at toddlers, very early in the first part of the decade, not much exposure. But I would like to mention here that those who have come with HAV seropositivity, this is not exposure, sorry, this is HAV IgM seropositivity. Those that came with seropositive, we had children as young as 2 years coming to the hospital, and they were found to be intensely antibody positive for the virus. So in other words, it implies that very young children are also left very vulnerable to the infection. And you can see the seropositivity, HIV IgM seropositivity among the referrals for acute hepatitis being spread over the children, older children, the adolescents or teen years, younger adults, and much less in the older adults, because it is assumed that these individuals, the older individuals, would have been exposed earlier in their lifetime, and therefore they did not present with acute viral hepatitis attributable to hepatitis A. So you can see the infection is now affecting a younger age group. Why is it affecting the younger age group? Simply because they are not being exposed to the virus as early as they were a couple of decades ago. So we could summarize some of the findings in the epidemiological trends that we see today. There's a significant decline in HIV seropositivity in 6 to 10-year-olds. You can see the drop from 85 to 30. In children in the second decade of life, again, almost half. There's a diversity in seroprevalence. I remember I told you we are a very mixed population now. One part of the country may have very low levels of exposure. The other part of the country has high levels of exposure. And we are seeing more amount of acute hepatitis A, which has increased 3 to 5 times fold. And there's increased frequency of acute liver failure in children, mortality among adolescents, and an increased HIV burden in the form of acute hepatitis, particularly in adults in the upper socioeconomic class over the past 5 years. Now, acute viral hepatitis today manifests as self-limiting, and it could be on the milder side where the resolution happens very fast, or it could lead to liver dysfunction of varying grades with jaundice, malaise, dark-colored urine, right upper quadrant tenderness, etc. And they might have up to 2.5 times elevation of the upper limit of normal of ALT, and there might also be a synthetic dysfunction in the form of coagulopathy, hepatic synthetic dysfunction. And this we would call, the more that a synthetic dysfunction of the liver, this would go into the spectrum of acute liver injury. Then we have the next grade, acute liver failure, where there's very severe liver injury, coagulation abnormality, INR is greater than 1.5, and there is also encephalopathy in the same patient. In an individual who is not known to have previous pre-existing liver disease, and this illness is within a period of 4 weeks duration. The third category of severe form of acute hepatitis is acute on chronic liver failure, where acute hepatic insult manifests as jaundice. Bilirubin is more than 5 milligrams per deciliter, coagulopathy more than 1.5, prothrombin activity is less than 40% of the normal. And this is complicated within a period of 4 weeks by ascites and encephalopathy. And this essentially happens in a person who is previously known or may not have been diagnosed yet of having chronic liver disease. So this is acute on chronic liver failure. So these are the most severe manifestations of acute viral hepatitis attributable to hepatitis A. Now, this is a very nice study published by from ILBS. Dr. Ekta Gupta is also a co-author in this, where they looked over a period of from January 2014 to December 2022. They looked at 40,000 plus samples which had been referred for anti-HIV IgM testing. About 1,144 were found to be HIV IgM positive, others were negative, and some samples were excluded because of lack of sufficient clinical data, insufficient sample, or co-infections in these individuals. And they were left with about 690 individuals. And when they segregated them based on age, the pediatric population, which they call less than 12 years, adolescent 12 to 17, and the adult population that was above 18. The distribution was, of course, the maximum acute viral hepatitis was seen in the adult population, followed by the younger pediatric population, and a more, somewhat close behind was the adolescent population. And all these three groups of individuals manifested with either acute viral hepatitis or acute liver failure or acute on chronic liver failure. The acute liver failure was almost the same across the three groups, very similar. Likewise, the acute viral hepatitis also was quite comparable in terms of percentage for the population represented in these three groups was comparable. But if you look at the mortality in these three groups, it's particularly seen in the maximum, the least is seen in the children who were less than 12 years, somewhat more in older adults, and the maximum was seen in adolescents. So this is something worth noting. They had a 31% mortality in the adolescent group. Collectively, there was about 6.5% mortality, which is not a negligible amount in this group that was studied. And this highlights the fact that though by and large, HIV infection is a self-limiting infection, when it does occur in older children, adolescents, and in the adult population, it can have sometimes sinister outcomes. This is again data from here to bring out the difference in the HIV IgM positivity versus the HEV IgM positivity. We have been discussing with different groups all over the country, and this seems to be a universal phenomenon. You can see that the percentage positivity for HIV IgM exceeds HEV IgM much, much more, HEV IgM being hardly present. And with, if at all present, often we find it along with HIV IgM positivity, which makes it difficult to interpret whether it is some part of the anamnestic response. But epidemiologically speaking, yes, HEV can also transmit since their routes of transmission are very similar. This is actually looking at the month-wise seropositivity across the 10 years that we looked at. By and large, the positivity increased after the month of July in most of the years, except 2020, which was really an outlier, may be influenced by the patients who could come to hospital in the midst of the pandemic. But that trend is generally maintained. Monsoon and post-monsoon is what we are seeing over these 10 years. And this has been described in other studies as well, even from ILBS and from Lucknow. Now, I come to the hepatitis A genome to dwell a little on the molecular epidemiology of this virus. This is the open reading frame of the virus with the 5' non-coding region, the 3' non-coding region. This part codes for the structural capsid proteins. This part of the genome core, the 2B, 2C, 3A, 3B, 3C, and 3D are essentially parts of the genome that code for non-structural proteins. Most of the amplification and sequencing for this virus is done by using primers that target the VP1 or 2A region. And almost consistently, the genotype, rather subgenotype that we find in India is the subgenotype 3A. Less frequently, subgenotype 1A has been also reported. We looked at some of the cases of acute viral hepatitis and acute liver failure, those that we had sufficient sample and those samples that were more recent because we wanted to get a good yield of nucleic acid. And in collaboration with the National Institute of Virology, we were able to do a whole genome sequencing of some of these strains. And we found that as per whole genome sequencing and even sequencing the 5' non-coding region, our strains, irrespective of whether they were acute viral hepatitis or ALF, all belonged to genotype, subgenotype 3A. It had a 90% identity with the published GenBank sequences and approximately a 99.9% identity with sequences that NIV had got from Kerala, where they had many small outbreaks of small to medium outbreaks of hepatitis A virus infection, which had also led to mortality, particularly in adults. Interesting from our data here from CMC Vellore, there were 2 ALF cases where they found that at position 171 and 176, long stretches of amino acid deletions, anywhere between 13 to 64 amino acid deletions at these positions. And these same kind of deletions have been earlier published many years ago by Stanley Lemon as well in severe cases of acute viral hepatitis A. So this is interesting to note that perhaps those cases that present with severe forms may be having genotypic changes in the VP1 region. And they could find this significantly in the VP1 region. There were deletions in other parts of the genome as well, but they were short sequences. But these were fairly long sequences where the deletions occurred. Now, we do know that when we have the adverse outcomes of hepatitis A, such as acute liver failure or acute on chronic liver failure, in Western countries, they opt for liver transplantation. We know in our country, not only the affordability, but the access to a donor organ, the access to such kind of healthcare in our country is something that is not so accessible, not to speak of the cost that liver transplantation would entail for a person who needs it. So there has been a new modality of management, plasma exchange, and it has been increasingly used in both ALF and ACLF. Basically, many of you will know, but those who are not so familiar, this replaces the patient's plasma with fresh plasma from donors, thereby removing harmful substances or those that may be toxic for the system as a result of the exchange, and therefore helps to rejuvenate the liver function. It also reduces the amount of inflammation because some of the cytokines are also flushed out, and it stabilizes the patient's condition and increases the chance of survival. Very often, procedures such as PLEX may act as a bridge to liver transplantation, while the individual might be seeking a prospective donor or an opportunity to get into the waiting list for liver transplantation. Or in some individuals, it might even facilitate the native liver function recovery. There are high volume or low volume plexes may be used, but today we know that even exchanging 50% of the plasma, like low volume plex, has been found to be very beneficial to such kind of patients. What are the indications for plex? The presence, of course, of a deranged LFT and any of the following three criteria, which is an INR, which is greater or equal to 4. So the significant derangement of liver function in terms of coagulopathy, worsening of the INR over serial tests, and this is even after getting 2 doses of vitamin K 4 hours apart, and also worsening of the consciousness of the patient, altered behavior, which shows they are moving towards advancing encephalopathy. 2 contraindications for plex is when there is hemodynamic instability or the individual is also in a state of sepsis. Now, that would be the management of severe cases, since we are discussing the more adverse outcomes of hepatitis A. But we all know today we live in a world where we would much more advocate prevention than cure. For a country such as ours, where all these modalities of cure are not affordable for many of our citizens. So vaccination has to be stepped up in our young children as part of them getting it in the childhood immunization schedule. We need to also be looking at our food handlers. We know typically our street food and our food handlers, small outlets, these are the people who need to be educated of how this virus can be transmitted, not only vaccination, but education about how it transmits, how they can prevent transmission, and also the general population, because we know that now people are more into eating out as compared to earlier days where most of us had home-cooked food. People are eating out more and more, and therefore vaccination is something, the option of vaccination has to be made known to the population at large. Persons who are at particularly high risk, who definitely need to be vaccinated, are those with existing chronic liver disease, intravenous drug users, because you know they can pick up the infection if they share needles from somebody who's in the viremic phase of hepatitis A infection, men who have sex with men, especially because of oroanal contact, persons with high parental risk, again, because of the brief period of viremia of hepatitis A infection, persons traveling to hyperendemic regions, and also carers or close contacts of people who are having hepatitis A, and also caregivers in nurseries, as well as places where they are taking care of the elderly. The IAP has recommended a schedule for children between 0 to 18 years, but they actually, as per their schedule, this is the timing. Though 0 to 18 years is a very, very wide range, they recommend that at 12 months, the baby receives either a live attenuated vaccine or an inactivated vaccine. The live attenuated vaccine is single dose, and it can be given subcutaneously, less painful. For those who are prone to bleeding, a subcutaneous may be a better option. In the case of the inactivated vaccine, complete vaccination involves 2 doses, dose given at 12 months, followed up by the second dose at 18 months, and the inactivated vaccine is given intramuscularly. Needless to say, the inactivated vaccine is definitely more preferred in those who are suffering from any form of immunodeficiency, children born with primary immunodeficiency, or even older children, or even adults who are choosing to get vaccinated, those who have chronic liver disease, or any an inactivated vaccine may be preferred if we have a suggestion that their immunity is impaired. The choices for us today, we have Havrix, which is a well-known inactivated formulation. You can see all of them have an efficacy above 90%. So whether it's Havrix, Avaxim, HappyBev, all, you can see the manufacturers, the cost of the vaccine. This may be different across states with the MRP, etc. There's also the inactivated vaccine in the bottom row, BioVac A. The attenuated vaccine in the bottom row, BioVac A, which also provides an excellent efficacy. And cost-wise, it actually turns out to be more cost-effective because there's only 1 dose, whereas the first 3, the upper 3 rows, they are inactivated vaccines. So that cost has to be multiplied by 2. For purposes of completion, is there any post-exposure prophylaxis if somebody has had an exposure? Yes, there is. Hepatitis A hyperimmunoglobulin can be given. It has to be given no later than 2 weeks from the time of exposure. Ideally, as soon as possible. Best benefits are if it's given as early as possible. It's useful for those who have immunodeficiency, in whom vaccination will take time to develop a favorable immune response, and for those also who have chronic liver disease, and for those who are planning imminent travel. But ideally today, those who travel from a low endemicity country to a high endemicity country should be taking this vaccine as part of the slew of vaccines they take before coming to such countries. The drawbacks of post-exposure prophylaxis is, first of all, its availability. If you go around asking for HAV, IgG, hardly likely to be available. its cost is significant, and the duration of immunity, as you know, is very little, 3 months and maybe a little more, and does not provide long-term immunity. WHO position on HIV vaccination in a country that is moving towards intermediate endemicity, such as ours, it very clearly recommends integration of the HIV vaccine into the childhood immunization program. This is because if we don't intervene in this form, there'll be a large proportion of adults who will become susceptible. And as I had mentioned earlier, the fatality is not mere 0.1%, but it can be 2.1% or even more the older the adults are when they pick up infection. But in the midst of vaccination, in a country such as ours, we might be well advised to keep up the health education, advice on better sanitation and personal hygiene, particularly for those who are vending food and who are hoteliers, small shops that vend food, street stalls. We need to educate them about personal hygiene and also educate them about trying to improve their living conditions that would favor less transmission of this virus. And with that, thank you for your patient listening. I presume there'll be questions at the end of this entire session. Thank you.
So, ma'am, there's one question in the chat box. Ma'am, there's one question.
Yes.
In our setting, we occasionally observe cases where both hepatitis A IgM and hepatitis E IgM are positive simultaneously. How common is this co-infection in pediatric patients, and what would be the appropriate clinical and diagnostic approach in such scenarios? Are there specific factors or epidemiological patterns we should be considering when interpreting these results? What should be our next step?
Thank you for that question. Actually, this phenomenon used to happen a lot more earlier. We have even seen that in pregnant women and even in children. But lately, we are seeing that the occurrence or the prevalence of hepatitis E virus is much less. You saw the graph which I showed, and I mean, I think there are people in different parts of the country who are experiencing exactly the same. So sometimes we occasionally see, in fact, last week we had a case of a child who had HAV IgM, a whopping amount of antibody against hepatitis A virus, but very borderline positivity to HEV IgM. We even confirmed it with the second assay. So the deduction is epidemiologically, we know both viruses can co-transmit because both are fecally transmitted. But I would be inclined to think that lately when we see especially low amounts of HEV IgM, just gray zone positivity, that might be part of some kind of an anamnestic or response which is not specific for the presence of HEV. It doesn't mean we should let our guard down, but we need to watch this space. But I see this phenomenon much less. In terms of, we continue to test for both in terms of the laboratory strategy. But in terms of clinical management, it doesn't really change. It is all supportive management, particularly for a person who is very ill. Even if you do a plex, plex is not specific for hepatitis A virus. It is basically restoring the liver function by exchanging plasma. So the management will not change. To the best of my knowledge, nobody is seeing severe cases of HEV lately. But if there is a co-infection, management really will not change. I hope I've answered your question.
Yes, ma'am. Thank you, ma'am. So, ladies and gentlemen, AIIMS Rajkot extends its gratitude by presenting a token of appreciation to all the speakers. May I now request Professor Agarwal, organizing chairperson, to kindly present a memento on behalf of the institute.
Ma'am, thank you very much once again to be part of this CME and always encouraging us. So this is a small memento which we have designed, and for a token of appreciation from our side, we will be mailing it to you, ma'am. Thank you.
Thank you very much.
We will be sending the memento to all our speakers after the CME. Thank you so much, sir. On moving forward, I would like to introduce you all with our next speaker, Dr. Ekta Gupta. Ma'am is the professor and head, clinical virology and nodal officer for WHO Collaborative Center on Viral Hepatitis at the ILBS New Delhi. Ma'am is a fellow of the Royal College of Pathology, London. She has a keen interest in clinical and diagnostic virology and has been working incessantly for the past 2.5 decades. Words will fall short to describe ma'am's contribution in the field of viral hepatitis. She has special interest in hepatic and transplant-related viruses. Ma'am's profound knowledge would undoubtedly captivate our audience and provide them with valuable perspectives on viral hepatitis. Over to you, ma'am, Dr. Ekta Gupta.
A very good afternoon to all of you. Am I audible? Very good afternoon. Okay, I'll share my screen. I think Dr. Priya, ma'am. Can you see?
Yes, ma'am, visible.
Am I audible? Can you see the screen as well?
Yes, ma'am.
Okay. First of all, I thank AIIMS Rajkot, Dr. Ashwini, Dr. Abhishek for inviting me once again to this CME, and I congratulate you on your very interesting study that you presented. And so the topic which has been given to me is Beyond Elimination Targets, India's Roadmap for Hepatitis B and C Management. I bring greetings to all of you from our Institute of Liver and Biliary Sciences. And so I'll start with one interesting case scenario. A 46-year-old female, who's a known case of chronic hepatitis B on a continuous treatment. And as per the guidelines, treatment, the chronic hepatitis B disease is maintained, DNA was negative, quantitative HbSAg, though less, but it was in 3,000 international unit. Seroconversion from anti-HB to anti-HB from HBe antigen for almost now 4 years. Now, a 46-year-old female have long life to live. So the questions are, can my treatment be stopped? Do I have to take it lifelong? And is there any marker, a better marker by which my internal, the liver damaged by the hepatitis B virus can be viewed? Patient also landed into had rheumatoid arthritis, and the clinicians were concerned that should we start immunosuppressant or not. So these are the questions which are not, so we are moving towards a public approach of controlling hepatitis B and C, but there are individuals who require answers. We did HBV RNA, we are doing it under research use only. There was active replication happening. We told not to stop antivirals. And when you are proceeding with immunosuppressant, be very careful because there's an active replication, and do very advanced HCC surveillance also. So the question is that now it's time, public established, but now it's time we have to move towards individual management of B and C. This is why the talk is about. The World Global Health Survey has cautioned all the countries that please launch your control program in your countries. This was done in 2016 to 21. Most of the countries, including ours, have launched it. But again, alarming report came in 2024 that the deaths by viral hepatitis are still on a rise. The targets, because the topic was beyond targets, the targets which were set, and I would like to bring your notice to the diagnostic targets, were to achieve B diagnosis in 90%, C in 90%, and treatment almost 80% of the cases. But what have we got? We still are nowhere near the targets which we have set in 2030, right? So these are the percentage of patients who are receiving treatment, very less, and as well as for C. That is why today's theme of World Hepatitis Day 2025 is let's break it down. So let's break down these viruses. Let's focus on where we are going wrong and what more needs to be done. We still have 304 million patients who are living with hepatitis B and C. And as clearly said, only 45% are receiving that at birth vaccination. Mortality is also rising. So now we have to identify what more needs to be done. This is a snapshot of what India has done. We have launched a National Viral Hepatitis Control Program. To remember, there are 5 viruses which can cause hepatitis, hepatotropic in nature, A, B, C, D, E. Dr. Priya ma'am has clearly explained what needs to be done. B and C and D, I'm going to focus. E, I don't know, maybe some other speaker will focus on it. In B and C, still, despite a program, we are second most globally after China. There is a lot of infection happening, which we don't know. And there is a high burden, as already shared in the rural area, of more children and adolescents which are underdiagnosed. And there is a high of infection in those who are having HIV, injectable drug users, and pregnant female. A very good study done and initiation by you, because yes, this is a focus area for all of us. This is a study which we have done from AIIMS and published, and in 2023. In this, I really wanted to highlight the etiological fraction of HCC. So hepatocellular carcinoma, although diabetes and NAFLD are the leading causes, B and C are still existing. Interestingly, you will see that C can cause HCC in non-cirrhotic liver. We know that occurrence of HCC is when the liver fibrosis moves. So you have a healthy liver, fibrosis 1, 2, 3, 4, and then it's HCC. But B and C both can cause non-cirrhotic HCC. So time has come that we don't have to target for treatment only those who are having symptoms where the liver damage has occurred. We have to catch the damage has not occurred and start focusing treatment and management in them. This is just a snapshot of all the hepatotropic viruses, A, B, C, D, and E. Only thing is, again, hepatocellular carcinoma risk is still there with B, C, and HDV. So we have to, so ultimately viral, we don't have to control the viral infection. We have to focus on the damage to the liver. A and E can cause damage to the liver in form of liver failure, as already mentioned by the previous speaker. But B and C, apart from liver failure, can ultimately lead to hepatocellular carcinoma. For B, you have treatment. For C, you have treatment. For B, you have vaccine also. So we have to focus ourselves on beyond control of B and C. First thing which all of us have understood is we have to enhance testing and screening. Right now, we are giving the testing, those who are donating blood and or organs, those who come up with abnormal liver function test. But once person comes with abnormal liver function test, harm to the liver has already started. Pregnant females, unfortunately, screening is done for B. I really like AIIMS Rajkot initiative, that C, and we have to bring it, that C is also screened in them. We are doing family screening of an index case, but it's only limited to husband, wife, siblings, not to all the people with household contacts and other cases. So it has to be enhanced. And these are the other conditions. Now, what globally people are saying is that we have to increase the screening. CDC last year have recommended that all adults who are more than 18 years should be tested for 3 markers to be, that is surface antigen, anti-HBs, and total HB core once in their lifetime. And they have really started, because they say that you have to pick up B infection by also doing HB core total. We are not doing this core total testing even in our blood banks. So we are just screening our population by HBsAg. So is HBsAg good enough? No, we have to have anti-HBs and total core. I know the finances, and to go about with such a wide country and to have these 3 markers introduced in the public program is difficult. But once we are doing a screening camp, should at least involve all these 3 tests together. We should integrate the testing for B and C with other syndromes like HIV, syphilis, and tuberculosis. Again, pregnant females needs to be screened for both B and C, not only B. Family screening needs to be enhanced. You only do not have to test for the spouses or children who are living with their household contacts, the brothers, sisters, everyone. So you have to increase the family screening. And early perinatal testing for both B and C should be incorporated. This is same. The WHO also says that as I said, move from public-centric approaches to patient-centric approaches. So time has come that start taking care of individual case-to-case scenario. How can we do that? By decentralizing. Decentralization we have also done. AIIMS Rajkot has also done. Also by task sharing. So bring about non-specialist who can be your champions for testing as well as treatment. It's very easy. B and C treatment guidelines are very, very easy. So you just need to train those people, and then you can get the results. Reflex testing approaches. So they can be lab-based reflex or clinic-based reflex. Lab-based reflex is very, very good if we can have it, that any serological test comes positive for B, that is HBsAg or anti-HCV, immediately the viral load should be done despite looking at the clinician risk request, and the patient should be informed and should be put into the cascade of care. Clinic-based is that the clinician receives tests by one visit by an RDT, and they're only looking at the result. They reflexively collect the blood sample for doing a viral load. More innovation in sample collection and transportation should be encouraged, like dried blood spot. It is a very good method, and you do not require fancy -80 or cold storage containers to transfer these specimens. It's a very easily you can collect. They show a good concordance, sensitivity, and specificity. Focus on the health worker support. So lay health workers, should be educated, capacity building should be done, and they should become your champions for hepatitis B and C testing, putting the patient on cascade of care and treatment initiation. Start putting clinician reminder, like electronic reminders. Any high-risk group comes to your clinic, syphilis, TB, they should be immediately screened. Prompt should come that screen for B and C as well. So these are few techniques which the WHO has said. We have evaluated a lot of dried blood spot testing, and a very interesting study which we did, which I would like to focus. Dr. Priya ma'am is also there. Between ILB, we collect spots and actually put them into a simple letter and simple post service, and posted them to these far distant sites, and tried to look at the serological reports between the three labs. We also stored them at different temperature for a longer duration, and we found a very good concordance between all the three labs as compared to HBsAg and anti-HCV positivity. So this is a real life study which we have done to show how effective this method of sample collection. This study has been there, but I just want to tell you, in this decentralization study which we did in Delhi State, that easily you can make health workers who are sitting in these mohalla clinics to give treatment for hepatitis C as well as for B, and train them. So we are regularly training the healthcare workers, simple who are sitting in these mohalla clinics, and making them champions for B and C management. So coming to hepatitis B in a nutshell, what all we have to do now beyond the national program? We have to identify cases, and emphasis should be on asymptomatic cases. So you should know what are the phases in which these asymptomatic cases occur. We need to monitor them better. We need to move towards the treat all concept in treatment, and we have to prevent the gaps in the vaccination, means adult catch-up vaccination strategies. Just revising hepatitis B virus with you all. It's a partially double-stranded DNA virus. The important targets, there are 4 open reading frames, and important targets for diagnosis antigen followed by DNA, right? You acquire infection during your younger childhood, more the chances that you'll land up into chronicity. Adult age, you acquire infection either through contaminated blood products, unsafe injections, more chances that you're able to clear the virus infection. So typically, if the virus gets cleared from the blood within 6 months, we call it acute. That is, the body's immunity has cleared the virus, but the virus never goes from the liver, remains integrated. Chronic infection, if the virus persists in the blood beyond 6 months. Now, to understand what is happening and how we can pick up more cases of hepatitis B, host immune responses and hepatitis B virus battle needs to be understood. So there's always a constant fight between the virus and the host immunity. This has become the basis of the new nomenclature. So the new nomenclature is that there is a first phase which is called as E positive chronic infection. Here there is an infection, virus is replicating high, but the ALT is normal, so the patient is asymptomatic. This is the phase where we have to catch them. Unfortunately, right now, the treatment in our guidelines is not for this phase. We treat patients once the liver damage starts occurring, that is, once the ALT starts becoming abnormal. We want to catch patients here, and we normally catch them when they come accidentally to donate blood. So they are known as incidentally detected hepatitis B surface antigen HAS. Then there comes a long phase when the virus is under the control of the human immunity. We call it E antigen negative chronic infection. Infection is still there, minded. Only thing is ALT is normal. Again, you need to catch them in this phase, because once the reactivation starts, immediately they go into liver failure, and the treatment is offered here, but then much damage has already occurred to their liver. So right now, the treatment is given not to all, but only in select group, as I said, phase 2 and phase 4, when the ALT is abnormal. And if the treatment is given, it is given lifelong. This is a simplified algorithm which we follow under our National Viral Hepatitis Control Program. We always look for HBsAg. If it is positive, then you go and see whether cirrhosis or no cirrhosis. Cirrhosis, treat. If there is no cirrhosis, look for ALT, which I told you is a marker of damage to the liver. Persistently abnormal, elevated means 3 counts are abnormal, you treat, or else you look for DNA. If more than 20,000, treat. Not more than 20,000, you can actually look at other markers. So what we are doing, we're not treating all. We are only looking that the virus is causing damage to the liver, then we are treating. Treatment is by these nucleoside analogs. nucleoside and tide analog inhibitors, and they're very good drugs. Not resistance is not coming, and they are pangenotypic, so you don't have to do genotype and all those assays. Now, what WHO in its latest guidelines has expanded, what they are saying, which I think the government of India or our national program should adopt, they're saying don't wait for a cirrhosis. If HbA1c is positive, and they have expanded the guidelines to include more than 12 years, also included pregnant and not pregnant females. They have also said that you can use these drugs to 3 to 12 years with caution. However, more than 12 means adolescent age group is included. They say that if there is significant fibrosis, start treatment. If DNA and ALT, if more than 2000, start treatment. If there is any comorbidity like co-infection, family history of cancer, cirrhosis, patient has got diabetes, metabolic associated steatotic liver disease, anything, start treatment. So they have expanded the treatment age group. They have included the group to beyond 12 years and said that we can go ahead and any comorbidity and you can give the treatment. So one needs to adopt to these treatment guidelines. So strategic shift which requires, if we have to move towards elimination, is that you have to move even beyond 2024. You can have a debate on treat all versus treat select, because if there is a virus in the body, and I'll show you what harm it can do, you might as well go for treat all concept, because drug resistance to these antivirals is not there, is minimally recorded. Then you can go and start treating asymptomatic cases. Why wait till the damage has occurred? As clearly I have shown that B and C virus can cause non-cirrhotic HCC, so you should treat them. Then identify markers by which treatment should be stopped. You cannot give lifelong. The first case scenario I said, you should have certain markers to stoppage of treatment, and treatment markers by which you can predict the reactivation of the virus. Now, why I insist that what is happening inside the liver, that presence of the virus itself is damaging. Earlier, when we had read that virus goes inside the hepatocyte, forms coiled CCC DNA, and that's the source of infection and a storehouse. Recently, the last decades, we have come to know that a huge amount is also integrated in the host genome, which we call as integrated HBV DNA. This integrated HBV DNA can cause mutagenesis, chromosomal instability, and can initiate HCC without even causing the cirrhosis. So that is why any amount of the virus, so we move beyond even treating the circulating DNA virus. We have to focus on CCC DNA and integrated DNA approaches. Based upon this integration, a lot of other new markers have come up nowadays, and it should be explored beyond HbA1c and DNA. Right now, we focus only on HbA1c and DNA, but you do have some correlated antigen, different forms of the HbA1c RNA, which all constitute to the newer markers in hepatitis B. So we have to move beyond current markers. We have to start evaluating at least that which other markers can be used, like quantitative HbA1c, correlated antigen, and HBV RNA. What is the role of E antigen and antibody to E? Earlier, we've read that E antigen is produced when the cell is actively replicated. But when it's a long-standing B infection, the virus undergoes lots of mutations, and especially the mutations at this site, which is the pre-core region, basal core promoter region, they make it E antigen negative. So in India, the studies have shown that 60% of infection is actually E antigen negative, because mother to child transmission, the age of the virus is the age of the person. So if the person is 40 years old, the 40 years aging virus is present. So a lot of mutations it has acquired. So the relevance of E antigen testing is decreasing. You just can't rely only on E antigen and wait for it to form antibody. However, those who are positive, in them, if you can do antibody to HBE, that will tell you a good host immune response. And it is helpful that the patient is moving towards the immune control of the infection. HbA1c quantitation has become, we've been doing it for the last 15 years, another promising marker, but it can help you in understanding whether the patient is moving towards the treatment control or not. However, since HbA1c is circulated in all the forms, it is truly not telling you about the CCC DNA or integrated DNA activity. It is always in excess. So now people are relying on many other markers. HbA1c quantitation has also come to a definitions of cure. So latest by EASL and APASL, they have changed the guidelines. They call 3 cures for the hepatitis B infection. A partial cure is considered when a patient is on treatment. DNA is not only undetectable, but even if it is below the lower limit of quantitation of the DNA assay, surface antigen has become less than 100 international units per ml. Despite not forming anti-HBs or CCC elimination, you call it a partial cure. So mostly our treatment is targeting partial cure. We are now advocating that we should move towards at least the functional cure, that HbA1c is lost, anti-HB normalization of ALT, anti-HBs may come, or move towards more sterilizing cure when everything has become normal and even CCC DNA is eliminated from the liver tissue. Although these are just goals for us to achieve, we should move towards achieving these functional or at least the complete sterilizing goal in patients. There are different forms of HbA1c, small, middle, and large, and their role globally, not in our country, has been established in identifying or predicting the HCC occurrence. It is said that if the large form of HbA1c is more in circulation, then there are more chances of HCC. So apart from doing alpha-fetoprotein or PIVCA, these forms of HbA1c can also be explored. However, you do not have any assay available in our country to measure them. Core-related antigen is another promising marker. It is considered to be a better marker than quantitative HbA1c, by which the transcriptional activity inside the hepatocyte can be measured. Although we do not, internationally you have few assays available, but in India, you do not have any commercial assay available by which a core-related antigen can be done. This is also a marker which can be done to predict the occurrence of HCC. HBV RNA, however, has come out to be a most promising marker, which we are doing under the research use. We have standardized our own HBV RNA assay, and we are trying to help our clinicians that whether the infection is under control or a reactivation predicting early reactivation in their patients. So our gastroenterologists in our research mode have started asking, like the case I showed, that can I stop, or if I'm going ahead and increasing the immunosuppression in my patient, what is the better marker for us to follow up a patient? We actually help them by doing HBV RNA testing. But however, commercial assays are not available right now in the country, so one can standardize them and can use them in the research mode only. Focus should be done on same-day reporting from HPV DNA. We don't want a patient who is infected and has got high DNA to go ahead and give a horizontal transmission. Any one single day with an HbA1c and HPV DNA positive patient can transfer to many persons. So one has to be very, very fast in reporting HPV DNA. The turnaround time by the lab should be the same day, and it should immediately put into the cascade of care. We focus on lab-based reflex testing. Ideally, the lab should incorporate that. If HbA1c comes positive, they should automatically do DNA and inform the clinician or put the patient into the cascade of care. However, clinic-based lab reflex testing is mostly the clinicians are doing. If they immediately, but in the single patient visit, they should not let the patient go out so that the horizontal transmission can be easily prevented. The another way by which we have to move beyond the targets of B control, enhancing the vaccination. We have a very good hepatitis B vaccine available. It is there, and country is focusing on at birth vaccination. But another area which is lacking is the adult catch-up vaccination. I think the universal use of hepatitis B vaccination in the national program came only in late 1990s, after 1995 or maybe 2000. So we have to at least catch up those who were born before 2000 and start vaccinating them, especially if there is underlying liver disease, diabetes, or compromised, then we need to be vaccinated. We need to see that all the 3 doses of hepatitis B vaccination are given, that is 016, or if it is a newer one, then 01, because you may get a anti-HPS titer more than 10 by giving 1 dose or 2 doses, but that is not going to give you a robust protection. For a robust protection, you have to ensure the dosage and the intervals between the dosage. First and 2 more than 4 weeks, second and third more than 8 weeks, and first and third at least more than 16 weeks. This will give you a robust immune protection. Once you have achieved anti-HPS more than 10, there is no need to do it again. It's done, and you have a documented proof. You can be rest assured that your body can mount a good immune response. We do anti-HBS. Normally, the CDC says that a healthy person who's fully immunocompetent, you should not do. But in healthcare workers, we still recommend getting an immune response check by doing an anti-HBS titer. Now, this one virus, I have clearly said that focus on catching them early, expanding the treatment, and catch-up hepatitis B vaccination, and more markers for monitoring. In hepatitis C, beyond what we are doing right now is that we should focus more on simplified delivery. Means it should be, because you have a very good test RNA, which is available, and all RNA needs to be treated. So now you have to focus on decentralizing them, make more and more point of care instruments available. Use of DAA should be expanded. Now the WHO has come up with more than 3 years guidelines, which can be given for HCV. So you should incorporate that. Along with that, counseling, because reinfection is coming up in high-risk group. So counseling and lifestyle modification is must in hepatitis C. This is a cleaner virus. It has got an antibody by which you look for infection. RNA, you do confirmation of ongoing infection, and all RNAs are treated. It is 8 major genotypes, and the treatment which is given is pan-genotypic. So we are not doing genotyping. So simply hepatitis C management, which our national program is adopting, is do an RNA and put the patient who are untreated on a 12-week course by giving a combination of 5A as well as 5B inhibitors. Do it for 12 weeks, wait for 12 weeks, and look for an SVR 12. So we give a treatment for 12 weeks, wait for 12 weeks, and check for a 12 week to have a treatment response. There is no need for on-treatment monitoring. Core antigen, though it is there recommended by WHO, but we do not have the many kits or rapid card tests available in our country, and so it has not been done. Genotyping is not recommended. However, genotyping and drug resistance testing should be done in certain select group of patients only. WHO has come up with this guidance for self-testing as they are promoting that decentralized testing. So they have come up with this oral kit, and it should be done as a self-testing manner. However, we do not have this kit available. So again, our national program has to move beyond getting these self-testing kits and make them available in India. Core antigen test can only tell you about initiation of the treatment, because there is active infection there or no active infection. However, you only have CLIA-based assay. If it comes as a card test, then it would be more appreciable and it will be more useful in our country. The WHO has enhanced its age guidelines for HCV treatment initiation. They have said that 3 to 5 you can give them with a caution, but above 12 you can easily start these and direct acting antiviral. So in our program also, we need to increase the age group from 18 only, which are candidate for treatment, to more than 12 years on treatment. do not forget that once you put so many on treatment, the drug resistance can come to HCV, although right now it is not there, not even in co-infected cases like HCV, HIV. We have done a couple of studies, but still be on a lookout if a patient is resistant to the treatment or it is presenting with a different clinical scenario. Delta virus, I just want to, because beyond B and C, so Delta virus is another virus which piggybacks on B. So it can cause infection only those who are B surface antigen positive. There are two forms of infection, both occurring together, causing co-infection, but can be fulminant, however, gets controlled very easily. So added infection on a chronic hepatitis B is more dangerous and can lead to severe disease. We published also, and we looked into the prevalence studies. And earlier, the prevalence of Delta virus was reported to the tune of 12%, 35%. However, recent studies in the last decade have not shown its prevalence, and we also did not show its prevalence, any significant prevalence, only less than 1% was reported. But globally, the guidelines have come up, whether it is ASLD, EASL, APASL, or WHO, they all are focusing that universal screening for Delta virus by doing an antibody test, IgG, as well as IgM and HDV RNA should be done in all HbsAg positive, at least in endemic countries, or those with advanced liver disease, and they in a high risk group. And they say that it should be a lab-based reflex testing for HDV in scenario. However, our national program is not has not moved to Delta virus screening, but yes, the focus can go, and we should look for the prevalence of Delta virus in at least those HbsAg positive which have advanced liver disease or they are high risk groups. So summarizing my talk, and we published this editorial, what are the strategies beyond the National Viral Hepatitis Control Program? Prevention, B, catch-up vaccination in adults should be promoted. A, as ma'am has said, we must focus ourselves on HAV vaccination. We have published this paper that in adolescents, HAV infection can lead to a lot many liver failure. And we in our institute are advising A vaccination in all those with underlying liver disease and comorbidities. E, though we do not have a vaccine right now, ICMR has done a couple of trials, but it is there in China and in Pakistan. And so till then, we should focus more on the water and food sanitation. Testing, I've highlighted, move towards journal and asymptomatic, integrate with other syndromes. Pregnant females, which AIIMS Rajkot has already initiated, B and C should be taken and screened for. Family screening should be enhanced, and addition of HDV screening, and treatment should also be enhanced to involve children and adolescents where this a huge burden of this infection is like. Thank you so much.
Thank you so much, ma'am, for this wonderful presentation. Ma'am, there are some queries in the chat box. Right now, we are reciting only two. The others will revert back via mail. So, ma'am, the question is, what is the role of quantitative HbsAg and core antigen in the management of HBV?
In the management of?
Hepatitis B virus infection.
Oh, I have said, see, quantitative HB, so when you treat a patient who is a hepatitis B infected, you have these nucleoside and nucleotide analogs inhibitor, which makes the DNA negative because they act on the polymerase gene of the virus. Surface antigen continues to occur, and as showed you, it's a marker of DNA as well as integrated DNA. So surface antigen on its own never clears, very, very rare. By doing a qualitative test you will do, it will keep on coming positive. DNA will be negative because you have put them on antiviral. So quantitative HbsAg can at least give a hope to the patient that yes, my burden of infection is decreasing. And now in the cure, they have said that if a patient has got less than 100 international units per ml of antigen, quantitative, you can call it as a functional cure of the infection. So now the guidelines have also incorporated. So it tells you a lot. So you can do an HPSAG and can look. Right now, don't stop the treatment for hepatitis B, but there are trials going on where, based on surface antigen quantitation, if it becomes less than 100 international units per ml, you can stop the patient's treatment. The other one was correlated antigen is a very new marker. We are at AIIMS evaluating it. We have the kit and the instrument, but internationally, people have shown that it is a better marker to predict HCC. As again, I have said that in the inactive career phase, when everything is controlled, sometimes sudden reactivation occurs and patient end up into liver failure and HCC occurrence. But at least you have a marker which can be done once in a year, like correlated antigen, and it is negative, then that's an important marker by predicting the occurrence, and any decision can be taken to go ahead with hepatectomy or transplant in such cases before the liver is damaged.
Thank you, ma'am. Ma'am, one last question. Which test should be best in post-exposure for hepatitis C? As according to MOHF, it's anti-HCV, and according to CDC, it's viral load for hepatitis C. And how often a person should get checked for viral load or anti-HCV after the exposure because of its chronic nature?
So post-exposure prophylaxis, ideally, if you ask me, the best test, there is a golden window, which is the first 2 weeks after 2 weeks of exposure. That should be HCV RNA. The antibody usually is formed after a month. But if there is an exposure from a person who has a high viral load, the chances is very high that you will acquire. Then go ahead and do HCV RNA. That is 2 weeks after exposure. But you also need to do anti-HCV at 1 month, because if you have got HCV exposure and the healthcare worker shows the presence of RNA in their body after the exposure, then treat them. Start early treatment before it can damage your liver and the virus gets cleared. So if it is just acquired, so HCV RNA at 15 days, if you have it is positive, then please initiate treatment to the healthcare worker. However, if HCV RNA is negative to 15 days, we look for antibody to HCV 1 month after the exposure and then 6 months after the exposure. And then only we say that you are clear, there is no threat of acquiring a post-exposure HCV infection. Ma'am has a question, I think.
Actually, thank you so much, Dr. Ekta, for that wonderful comprehensive presentation. I don't have a question. I just have an add-on comment to what you just said. We had a case where a medical officer had a needle stick injury from a post-renal transplant patient who was highly viremic. She presented with extrahepatic symptoms. Very early, 3 weeks following the needle stick injury. She had not reported it, but when she had these symptoms, when we interrogated her, we knew that she had had this exposure. So we started her on treatment promptly. And she, in fact, never developed antibody because she was treated so early in the course of her infection. She was viremic, genotype 1. She was treated. She cleared the infection, and as Dr. Ekta had said, you have to follow them up to make sure they have cleared the infection in the form of negative RNA. But because of the treatment being so early, the classical HCV antibody never developed, because antibody response is typically somewhat delayed compared to other viral infections in the case of hepatitis C. Just a comment.
And to add on to that, ma'am, as we have shown that B and C can cause so much of damage to the liver. So that is what we are saying, that why wait for symptomatic cases to treat? So you should, if you have the facility, do an RNA test, treat, so that no harm to the liver is there, even to the healthcare work. So excellent, ma'am. I think this should be the strategy, but for managing the post-exposure prophylaxis.
I think there's some more questions for you, Dr. Ekta.
Oh,
We will take it later.
Ma'am, we will take the other queries later on. So
yes.
I request Professor Agarwal to kindly present a memento to Dr. Ekta ma'am on behalf of the institute.
Ma'am, thank you very much. You are an integral part of our CMEs. This is the third time you are with us, and our team has already taken some research ideas from you this time too. And
Yes.
Sheikh will be discussing them with you shortly, ma'am. Thank you very much,
Thank
ma'am. The small token of appreciation from our side, and Dr. Abhishek will mail it to you, ma'am. Thank you, ma'am.
Thank you. Thank you so much. Thank you.
Thank you so much, ma'am. So on moving forward, now I invite our next speaker, Dr. Rahul Dhodapkar. Sir is currently serving as professor in the Department of Microbiology. Sir is currently serving as professor and head in the Department of Microbiology at JIPMER, Puducherry. He graduated from Gandhi Medical College, Bhopal, and earned his MD in microbiology from Kasturba Medical College, Manipal. With over 2 decades of academic and clinical experience, Sir has held various teaching and research positions at JIPMER. His areas of expertise include medical microbiology, infectious diseases, and molecular diagnostics. He has over 60 publications indexed in PubMed, and he has led and collaborated on several high-impact research projects funded by ICMR, DHR, and WHO, including national surveillance programs on influenza, encephalitis, rubella, and COVID-19. We are honored to have him with us today. Over to you, sir, Dr. Rahul Dhodapkar.
Yeah, thank you for this introduction. I would just like to share my slides. Are the slides seen?
Yes, sir.
And they're moving.
Yes, sir.
Yeah. So at the outset, I would like to thank the organizers putting me in league with all the doyens of hepatitis, Priya Madam and Ekta Madam. So I hope the lecture comes up to the standards which they would have set. I could not attend the initial 2 lectures because I was attending another training program. There was a clash of dates. So I'll just start my presentation. So the topic which Dr. Abhishek, he was in discussion with me and he said that, sir, we should have a discussion on hepatitis B in pregnancy. And this is a topic which I have to repeatedly answer questions because my spouse being an obstetrician, she keeps asking me and I need to keep updated to keep up with the questions which keep coming to me. So the topic is navigating hepatitis B in pregnancy, protecting 2 lives, current practices and updates from India. So I'll be discussing this topic under the epidemiology, a bit about hepatitis B virus, then a little bit about the pathogenesis, and then primarily going into the management of pregnant women and the strategies which we use to prevent the mother-to-child transmission. So this is hepatitis. Let's break it down. This is the theme for this year's World Hepatitis Day. And it is aimed at dismantling the financial, social, systemic barriers, stigma that hinder the global effort to eliminate hepatitis and prevent liver cancer. This emphasizes the importance of vaccination, safe injection practices, harm reduction, testing, treatment, and into the national health systems. And this is the goal, end hepatitis by 2030, that is the elimination of it. So looking at the worldwide prevalence of hepatitis B in Southeast Asian region, we have around 61.4 million cases of hepatitis B. And if we look at the Indian scenario, we have been in the intermediate category, the prevalence from 2 to 8%. Amongst the seroprevalence in pregnant women, this was a meta-analysis which was done recently. State-wise pool prevalence, if we look at it, the eastern and the southern zones have high prevalence of around 4%. The rest of the country having lower, around 1.8 to 1.7% prevalence. And we have data missing from a large part, the northeast, then the Chhattisgarh and the northern parts. This is an extract from the same paper, which gives us important insights about how the hepatitis B scenario in pregnant women is there. And if we look at the data, amongst the patients who were seropositive, around 72% had detectable HBV DNA, and alarmingly, 26% had HBeAg positive, which indicates that it was a replicating virus. And to understand, which I'll be talking about subsequently in my talk, the transmission from mother to child happens more so when the virus is replicating high, or to put it in simple terms, if the patient is hepatitis B E antigen positive. So this is an alarming figure, around 26% having replicating DNA or highly replicating DNA capable of transmitting. Rest of the data is about the percentage prevalence or the odds of the infection being seen in urban or rural area, or along with the literacy. Another, although not significant, but alarming, was the seroprevalence was higher in the younger age group, less than 25 as compared to more than 25. Now, this was a bit alarming to me because this is a generation where a part of them have got vaccination, or the part of them are amongst those where hepatitis B vaccination has been brought into the national immunization program. So in this group, having a higher prevalence was a bit of alarm. And the risk factors which have been seen, another thing which is alarming is the current trend of tattooing, because the tattooing was associated with around 22% of cases. Hepatitis B in general, I was just planning to cover a bit of it because students would be there in this CME. It's a DNA virus, partially double-stranded DNA virus, which is enveloped and has got multiple morphotypes because of the surface antigen, the spherical, the tubular, and the complete form. And here, mind you, the surface antigen exceeds the DNA quantities. They do not go in the ratio of 1:1. The hepatitis B surface antigen is 10-fold more than the viral copies. And that is where the utility of surface antigen has been somewhat limited, although as in the earlier lecture, Dr. Ekta mentioned, there is some role of surface antigen in the prognostic management. Modes of transmission. The most common modes of transmission have been the perinatal transmission, which we are going to stress now. Then apart from that, the other important thing is the horizontal transmission, which happens through the needle stick, the injectable needles or the injectable drugs. And same route goes in our healthcare setup, where because of the needle stick injuries, the transmissions have been seen. Apart from that, unsafe transfusions, which are to far extent being limited by the strategies which have been adopted for the screening of blood and blood products. Sexual transmission is another route. We'll be stressing about the perinatal transmission today and the factors which affect that. The virus enters through the sodium taurocolate co-transporting polypeptide receptors, and after that it enters and replicates within the cell. There are important components of the genome. The open reading frames are the S gene, X gene, P gene, C gene, and the pre-C gene. The S gene codes for the surface antigen, which happens to be the marker, the most common marker, and the core and the pre-core genes code for the core antigen and HBeAg, and in fact the core related antigen, which currently is coming up as a marker of clearance of virus, also comes from these C genes. So these are important from the diagnostic perspective. Now, if we look at the screening for the mother to child transmission, how the antenatal case should be dealt with. I'll be talking about this repeatedly through the course so that it gets well emphasized. So screening should be done at least once as early as possible in the pregnancy and may be repeated if the patient is coming from a high risk zone. And this screening should be a serologic screen using a surface antigen as a marker and preferably in a laboratory setting. When I say laboratory setting, it should be a lab-based test like an ELISA or a chemiluminescence. And if not feasible in the particular healthcare setup, it could as well be a point of care test like a rapid test, which can be used at the clinical end. Now here, once the patient is tested and if the patient is positive, then the patient should be offered further tests so as to evaluate the case as to whether they need to go for hepatitis B care or the treatment for the case for the patient's perspective or from the perspective of prophylaxis, and to evaluate the case. If negative, the patients can be documented as negative, and as I emphasized earlier, it can be repeated if the patient is high risk, like patient has multiple sex partners or has the partner or the patient has injectable drug use or household contact of hepatitis B is there. Different serologic tests are there and they differ in their sensitivity. Most commonly in a hospital or a lab setting, the tests which are used are either ELISA based or chemiluminescence, depending upon the workload of the lab and the infrastructure which can be provided. Apart from that, at a primary healthcare level, the rapid tests can be used. They do differ in their sensitivities. Chemiluminescence is the lowest limit of detection, or the sensitivity is up to 0.05 IU per ml. ELISA having 10-fold less, around 0.5 IU. The RDTs have further lower sensitivity, but however, for most of the cases, they do suffice, and there are very few cases where you would need something which where you need to go for a next level of testing. So this is further about the assays, the chemiluminescence, ELISA. The sensitivity of chemiluminescence is around 98 to 100%. ELISA has around 88% versus CLIA using as a standard. RDT will have a sensitivity of around 72 to 99%. Others are core antigen and Western blot. I will not be discussing much about that. Can do with ELISA. Then the next level of tests which are required for management is the viral load, which can be done on automated instruments like Cobas or Abbott. In fact, I would be suggesting subsequently that we can also standardize the Indian tests against the international standards and start using them. I'll tell you about the rationale in the subsequent slides. So looking at hepatitis B, the outcome of hepatitis B depends on when the infection is acquired and what is the immune status of the patient. In an adult case, hepatitis B, if acquired, which is most of the times horizontally acquired, either sexually or through a needle stick injury, the outcome is more or less good, where only 1% move to permanent hepatitis, 9% will go for chronicity, 90% will have a resolution. This 9% which go for chronicity may persist as chronic persistent hepatitis or chronic active hepatitis. Here we should keep in mind that our body is never able to clear the hepatitis virus once it infects. And this is something which we have to keep in mind. The students who are there in today's audience, they should not get confused by this 90% resolution. It is only a clinical resolution. The virus persists. The virus persists in the body in form of cccDNA and may reactivate at any stage if the immune system is compromised. This is a very important thing which we have to keep in mind with hepatitis B. This is in contrast to hepatitis C, where after appropriate treatment, you have a complete viral clearance. Hepatitis B, we do not have that. Now, the other routes of transmission which happen are the mother to child transmission, or the vertical transmission, or perinatal transmission, where the infant is infected when his or her immune system is not mature. And this is a scenario where most of the times the virus is not cleared and a chronic infection sets in. So a vertical transmission from mother to child, or somewhat later a horizontal transmission which may happen, or I would say there is another term which most common, many times it is not used, but recent literature showed that where we say that most of the transmission in India which happens is a horizontal transmission at a toddler age because of close contact between children. But there was a recent study which had come up from SGPGI, where they demonstrated that most of these chronic infected children in India, they had their genotype similar to their mothers. So maybe it is a vertical transmission happening from vertically at the time of birth, or it could be a horizontal transmission which may happen from the mother to child at a later stage. Now, coming to the effect of pregnancy on hepatitis B infection. Now, pregnancy is a state where the body of the expectant mother is compromising itself so as to accommodate another being within. And this is where there is a shift in the Th1, Th2 balance towards a Th2 response, which is increased amounts of regulatory cell. That means a depressed immune response against hepatitis B. An aim of these modifications physiologically is to prevent the rejection of fetus who's partially allogenic for the mother's immune system. And these modifications result in increase in HBV DNA and reduction in amino transferases. So patient moves towards a more of immunotolerant phase where the control on the virus which is there loosens, as well the reactivity to the virus or the damage caused is also reduced. So because of that, HBV DNA goes up and the amino transferase levels also come down. After delivery, the immune system is restored, thereby causing opposite consequences. There is significant increase in ALT and reduction in HBV DNA. This is something which we will be mentioning subsequently. There are ALT flares which are seen. HBV flare or ALT flare is something which is seen in patients who are hepatitis B positive and then subsequently conceive. So this is what I was talking about. Impact of pregnancy on hepatitis B virus infection. The most common problem which is seen is hepatitis HBV flare or ALT flares, which are defined as more than 2 times increase above the upper limit of normal. So transient transaminitis is there, may or may not require treatment. Now, I'll be walking you through this topic. I'll be talking about how do we manage these cases, because this is a question which, as I told you, I have been fielding it apart from within the family and as well from the clinicians, how to manage these cases. So HBV patients on long-term nucleotide analog therapy, there are good treatments available. What we have to see when we are dealing with this infection in patients who are pregnant is whether the therapy which the patient is taking, is it suitable for her pregnancy or not, or whether is it a treatment which can be given to a pregnant lady. So we have some drugs which are category B, which can be safely given to the patients. These are telbudine or tenofovir, TDF, and then some of them are category C, lamivudine, adifovir, and entecavir. These all are commonly given in the program. In fact, if you read the National Viral Hepatitis Control Program, these are all recommended drug for hepatitis B patients. Now, this choice narrows down to only category B drugs when we have to treat a patient who's pregnant. So this is one thing which we have to see, that when the patients are pregnant, patients who are on long-term treatment, when they are pregnant, then we have to see that the regime is shifted from a category C to category B. These ALT flares in pregnant women, when the therapy is stopped for some time because of the pregnancy, then ALT flares become common. These are more common because the patients are young in age and most of them are in an immune active stage. Then treatment of for the treatment naive chronic hepatitis B infected patients who become pregnant. So here these are the patients who have not been treated, who have chronic hepatitis B, who do not require treatment, how to manage them. So here we need to closely monitor them because the risk of HBV activation is high because of immune reconstitution. There can be increased hepatitis B or hepatitis HBe antigen. As I told you, pregnancy is a state where the immunity becomes compromised to accommodate the fetus, and in this stage, hepatitis B virus, which otherwise might not be in the range, or the patient might not be in a staging which requires intervention, may become come in a stage where some sort of intervention may be required. Most of the ALT flares happen in the second trimester, where the hepatitis B viral load goes to more than 2 log, and sorry for a typo here, an ALT flare where the aminotransferases may go above 5 times the upper limit of normal or 3 times above the baseline. Close monitoring of patients for these flares or increases who are not on nucleoside regime is required, and monitoring should continue for up to 6 months postpartum. Then patients who have portal hypertension or in chronic hepatitis B infection with established cirrhosis, this may be enhanced because of the physiologic changes in pregnancy. And here the MELD score, the model for end-stage liver disease score, is predictive for significant liver disease-related complications, and MELD score of more than 10 is usually predictive of liver decompensation. Now here, in these patients, the complications which can be foreseen is acute variceal bleed, which happens in around 18 to 32% of the patients and is fatal in quite a few of them. For these patients who have already cirrhosis or have portal hypertension, these patients, there should be a thorough surveillance, endoscopic surveillance for varices, and a prophylactic ligation of medium and large size varices should be done. If bleeding risk is still high, then they might be considered for beta blockers. But when you give beta blockers, there is a chance of, there is a requirement of fetal monitoring because the risk of fetal bradycardia or IUGR can be there. So to summarize the recommendations for hepatitis B with pregnancy, patients who are already on treatment because of advanced disease, continuation should be there. As I told earlier, they should be shifted from class C to class B. Those who are on treatment with less advanced, they should again be continued with the treatment, and as mentioned earlier, from class C to class B, the drugs should be changed. TDF is a recommended first choice antiviral for pregnant females. For chronic HBV infected females who are not eligible for antiviral treatment, they should also be monitored for HBV DNA and ALT levels, and throughout the pregnancy as well, up to 6 months after the pregnancy, because of the risk of flares. The patients who have established cirrhosis, they should undergo a surveillance endoscopy to screen for varices, prophylactic variceal management may be recommended. And those who have larger varices, for them endoscopic ligation of medium to large size varices should be done. Now coming to the mechanism of mother to child transmission of hepatitis B virus. Now the transmission of hepatitis B can happen at 3 stages: in utero transmission or prepartum, during the delivery, and postpartum, intrapartum and postpartum. Now, HBV in utero transmission, lot of theoretical risk is there because replication has been demonstrated, the virus has been demonstrated in the ova. Then there has been some evidence where the virus, the replication in placenta has been demonstrated. And the viral antigen and the DNA has been demonstrated. This was a study which was published recently, I think from Bhopal, and I think AIIMS was a part of it, where they studied the placental tissue and they could demonstrate the receptors, the HBe antigen, core antigen in the trophoblast. They could also demonstrate HBV DNA. The viral DNA pre-genomic RNA has been demonstrated. So it gives us a very good proof that placenta may act as a source of virus. But if we look at the prophylaxis which is given and the success of prophylaxis, it does point that the in utero transmission is a very low probability. The most of the transmission which happens in the intrapartum period. This is either in the first stage where the repetitive strong contractions may cause maternal-fetal microtransfusion, or in the second stage where the infant directly comes in contact with maternal HBV containing body fluids. So this by far is the most common route from where the transmission can happen. And then the third is postpartum, where there is a theoretical risk through breast milk. However, I'll be talking about these things subsequently also. Breastfeeding is not contraindicated in most of the cases, unless there is a visible injury, excoriation, or cracks or bleeding around the nipple area. Breastfeeding is always recommended. The risk factors which contribute to mother to child transmission, the most important is the HBV DNA, the quantity of HBV DNA. Presence of HBeAg correlates with high viral load. So HBeAg's presence of HBeAg also refers to higher transmission. And then the timing of immunoprophylaxis. This is very important because if we look at the control strategies, the first birth dose of hepatitis B is most important in cutting down the transmission rates. So without any intervention, in a hepatitis B surface antigen positive patient who's E antigen positive, the transmission is around 70 to 80%. In E antigen negative cases, 10 to 30% transmission is there. Now with a timely birth dose, the single dose of vaccine which is given within 24 hours of the birth, it cuts down the transmission by 70%. Adding a timely vaccination, complete vaccination, that is what we usually give along with the Pentavax 6, 10 and 14 weeks, it cuts down the transmission by 95%. So these are two important interventions which should be undertaken if we need to control the hepatitis B vertical transmission. So all infants should receive birth dose of hepatitis B vaccine within 24 hours of birth, followed by complete vaccination series. And here, preterms should also be given the vaccine. Although the immune response in them is less, but being a preterm is not a contraindication. It is not a live virus, so the vaccine can be given in preterms. Then coming to the role and utility of hepatitis B immunoglobulin. Now, this is another important intervention which is done to cut down the transmission, the vertical transmission of hepatitis B from mother to child. Combination of hepatitis B birth dose with HBIG is the most optimal strategy for all infants born to mothers with hepatitis B. But it has been observed that in HBeAg negative mothers, HBIG or the immunoglobulin doesn't give any additional protection. In hepatitis B E antigen positive mothers, appropriate vaccination alone without immunoglobulin gives a protection of around 95%. And appropriate vaccination along with the TDF prophylaxis for mothers can reduce HPV transmission to very low, around 1.48%. We are talking so much about immunoglobulins because when we look at the logistic aspect, the programmatic aspect of bringing in these interventions, then immunoglobulin is one of the bottlenecks because of its cost and availability. These are expensive things, may not be available at the smaller health centers where the patients may deliver. In fact, in the big centers also, a regular supply sometimes may be challenging and the patients have to pay out of the pocket to get these things. So we are looking at the ways where we can circumvent this and move forward. If it is there, it is always the best strategy as it has been emphasized in the given slide. Now, another thing which can be done is antiviral therapy for prevention of mother-to-child transmission. Now, here we will be talking about the prophylaxis which is given. Mind you, this is not about treating the patient for their own sake. This is about the prophylaxis where we want to cut down the transmission. So, antiviral administration to HBsAg positive mother is useful in reducing the transmission. And TDF has the highest drug resistant barrier and hence is preferred. Now, there are guidelines. In fact, recently WHO has come up with a revised version of its guidelines where it has discussed amply about the mother to child transmission and what intervention should be done. And one of the recommendation is maternal HBV threshold of more than 2 lakh IU per ml or 5.3 log IU as the cutoff, above which a prophylactic TDF dose may be given to the mother to cut the risk of transmission. Now here the decision to initiate is as per the viral load, where the quantitative estimation of hepatitis B DNA copy numbers is essential. Other triggers which have been recommended is HBeAg estimation by immunoassay technique, HBeAg negative with a persistent raised ALT or quantitative surface antigen detection. But the reference would always remain the quantitative estimation of DNA. So this was the guideline which I was talking about. So in settings where HBV DNA or HBeAg testing is available, this should be done, and the patients with HBV DNA of more than 2 lakh IU should be offered this prophylactic management. In settings where neither HBV DNA or HBeAg testing is available, there, just based on surface antigen, TDF prophylaxis has been recommended. However, this is a conditional recommendation with low certainty of evidence. And these all interventions should be given along with the 3 doses of hepatitis B vaccination, including the timely birth dose. So that doesn't go anywhere. Those are there. These are additional recommendations to cut the transmission. Now, this therapy should start as early as possible. However, there is not much of a difference, but what the recommendation says is it should start before 28 weeks. Whether the cessation of therapy with childbirth increase the risk of flare? No, it doesn't increase. Any flares which may be seen are clinically non-significant and do not warrant therapeutic intervention. So for the prevention of transmission, all the newborns should receive the first dose of hepatitis B vaccine as soon as possible. This is the first and the most important intervention which is required to cut the risk of transmission. And this should be followed by 3 doses of complete series of vaccination, which we will be referring as Hep3. Next is about the immunoglobulin prophylaxis, which should be in conjunction with HBV vaccination, may be of additional benefit in patients who are HBeAg positive or those who have a high viral load. Tenofovir prophylaxis is pregnant women who have a higher viral load, around 2 million copies, and this also helps in cutting down the mother-to-child transmission. For pregnant women with high viremia who are visiting hospital after 28 weeks, antiviral intervention should be initiated immediately. Pregnant females taking antivirals for prevention of mother-to-child transmission can continue antiviral treatment immediately after delivery or up to 12 weeks postpartum, but should be monitored up to 24 weeks for the HPV flares. Then about the child. When should we assess the child, whether the child has acquired infection or not? So this follow-up should usually be delayed up to the child being around 9 to 18 months in age and should be done 1 to 2 months after last dose of HPV vaccination. Post-vaccination surface antigen and anti-HBs should be done after 9 months, because this immunoglobulin administration can give rise to a false anti-HBs, and administering hepatitis B surface antigen also may sometimes give a false surface antigen test. So most of these tests should be delayed up to the age of 1 year, after which the child should be tested to know whether the child has acquired infection or not. Anti-HBC tests should not be done in babies born to HBsAg positive mothers because maternal antibodies may persist up to 2 years. As I told earlier, breastfeeding is not contraindicated, and if mother is on antivirals, these drug concentrations are much lower, and the mothers may continue to breastfeed. So, coming to the public health aspects of HBV infection in pregnancy, hepatitis B is a major cause of morbidity and mortality, and elimination for hepatitis B is defined as 90% reduction of incidence or 65% reduction in mortality. The best measure for the reduction in hepatitis B prevalence is looking for prevalence in children less than 5, and this should come down to around 0.1% by 2030. And this can be achieved by 90% coverage of hepatitis B birth dose vaccination and 90% coverage of hepatitis B 3-dose vaccines. If we look at our data, Indian data, we are good with the 3-dose coverage. We are somewhere around 88-89%. This is the data, I think, a couple of years back, around 2 to 3 years back, where the 3-dose vaccination was good enough. But if we look at our birth dose vaccination, that is still very dismal. I think we have it in 44 to 45% of cases only. So this is one major gap which we need to cover. Hepatitis B screening in pregnant women should be done as early as possible. Should be a lab-based test, preferably, as I emphasized earlier. RDTs can be employed if the lab tests are not available. This is a bit from the lab perspective. If the regional prevalence is more than 0.4%, then we need not do a confirmatory test. If it is less than 0.4%, then a confirmatory test for hepatitis B is required. Pregnant females found hepatitis B reactive may be offered a viral load or HBeAg test to assess the eligibility for therapeutic intervention. Infant vaccination alone may not be sufficient to reach the goal of elimination by 2030. So here we may have to add other things, the timely 3-dose vaccination, which can help us in cutting down around 14 million cases, adding tenofovir to the management may further cut down around 2 to 3 million cases. So it has to be a concerted effort which has to be taken to reduce the transmission of hepatitis B from mothers to children. So this is just a snapshot of what the guideline talks about, the current hepatitis B guideline, where if the viral load is less than 2 million or 2 lakh IU, and patient is HBeAg negative, no tenofovir prophylaxis is required. If it is more than 2 lakhs, then maternal tenofovir prophylaxis may start from second trimester. Now, here comes the question of offering the prophylaxis without the viral load or without E antigen. Now, this sort of recommendation has been primarily directed towards the African countries where the lab infrastructure is very poor and they do not have sufficient molecular testing capacity. Then the other group of patients are those who require treatment. Now here also the 2024 guideline has brought down the level of hepatitis B DNA for initiating the treatment. Initially it used to be, earlier guidelines used to suggest 20,000 IU. Now the treatment can be started if the viral loads are more than 2,000 IU and the ALT levels are elevated. And this applies to pregnant women as well. This is just a case study from China. Now, if we look at their earlier data, and not a very old data, it is data from 1992, they had a population prevalence of around 9.72%, where they initiated the HBV immunization, which they increased to free HBV vaccine to all newborns, then complete free hepatitis B vaccine service in 2005, catch-up vaccination for less than 15 in 2009, and then triple elimination strategy, and then introducing other smaller efforts. And in 2022, their population prevalence has gone to 2%. Now, in India, many times the Chinese things are not taken very kindly, but then there are things which we can learn from them. And this is one big lesson which all of us need to learn. And our program managers need to learn that in a very short time, they have gone from a high prevalence, zero prevalence country to a moderate to and about to reach the low zero prevalence country. And mind you, China is huge. They were the most populated till recently we took over them. So to summarize, there are 4 major interventions which we need to make to cut down the hepatitis B transmission from mother to child. The first is the birth dose of hepatitis B. Next is the hepatitis B 3-dose vaccination, then immunoglobulin if required, and tenofovir prophylaxis. So these 4 can help us cut down the transmission of hepatitis B to very low, where we can match up with the developed countries. There are a couple of things which I thought I would also share. We were talking about the viral load testing. This is still limited in major medical centers and medical colleges. We need to move ahead and bring in more viral load testing centers into our country. And in fact, if we look at just a couple of years back, 2-3 years back, we had a massive infrastructure of molecular testing, which was established almost up to the district hospital level in most of the states for testing SARS-CoV-2. Now, the same infrastructure should be adopted so that these viral load testings can be made available to even the smaller settings, and appropriate management for the patients can be given. Thank you.
Thank you so much, sir. Sir, there is one question in chat box.
Yeah.
What are the chances of children with genetic abnormality born of a mother who is chronic hepatitis B carrier?
No genetic abnormality, nothing would be there. Only the risk is of transmission of hepatitis B. No other abnormalities would be there. The drugs which are given, they should be appropriately given. The category B drugs, if they are given, they are pretty safe. And for that, the guidelines are there. And we have actually affordable treatment which is available.
Okay, sir. Thank you, sir.
Thank you, sir. This is Dr. Ashwini from AIIMS Rajkot. We are thankful to you for sharing your valuable insight. But you missed the first study which we conducted at AIIMS Rajkot. It's about the public health aspect, and we are aiming to eliminate hepatitis by 2030. So in this study, what we found, it's a very interesting, some of the very interesting finding, and we plan to take it further. We went to the interior villages of Gujarat. We collected the blood sample from the women of childbearing age. And the seroprevalence, which was there in pregnant women, was 1.36% for hepatitis B and around 0.78% overall. So that is one aspect. But the main aspect is that none of these women, more than 90%, only 3 of them out of 34 knew about their HbA1c status. And even doctors who are getting them screened in peripheral health center, they are not aware of any guideline, any where to refer them if they are HbA1c positive. They are just focusing on major things like anemia. So they are still not worried about hepatitis B or hepatitis C. So even hepatitis C prevalence was around 0.33%. But none of the female was aware that they are carrying, and many of these females had pregnancy earlier also. They have got live children. So we are planning to go back to them and screen their children also, their family also, and maybe we will get some insight into it. The problem at public health level is availability, yes, of diagnostic test, of management, but also of the knowledge, which we should look into, sir. But if we are, and we have got Dr. Ekta and Dr. Priya with us. So whenever we are making policy, I think we should focus more to these places, peripheral centers, where nobody is taking hepatitis seriously. And I hope some of the practitioners are with us today from Peripheral Health Center. They have joined us, and they are able to get some take-home message from this CME. That's a comment from my side, sir.
See, most of the times what it happens is in the medical college setup, these patients would be managed well. Peripheral sites, especially the private hospitals, what they would do is, private in the sense the nursing home level, they might not manage them well, or rather they may show off these patients to a higher center saying you have hepatitis B or you have this. Maybe they'll surreptitiously screen them and send them for some other reason. So those sort of things do happen. They need to be made aware. And basically, see, it is about the awareness of the clinician regarding the disease and the further course. The further course is something which the patients many times may not, even the clinicians may not know what next to do. So in a medical college setup, that way it gets managed well. At least in our institute, these patients do get referred to medical gastro and they are managed well.
Yes, sir. In a larger center, yes, but in peripheral center, awareness is still lacking about hepatitis, and they don't take any HbA1c. Most of the HCV is never done. HbA1c, yes, it is done sometime, but they are not followed up as they should.
Now
That's all.
IDSP actually is covering that HMSC data which is covered, so they are actually seeking the hepatitis B data. So maybe gradually it is coming up. Hopefully it will go to the most peripheral centers and that should happen. Madam, you had a question?
Dr. Rahul, very nice presentation. It's not a question or query, but rather to augment what you said. I agree with Colonel Agarwal that education is a very important facet for the mother to know that she can transmit an infection to her baby. That's a very important. But I think the lowest hanging fruit for our country, I'm not discounting all the measures you mentioned, but India has had a reputation of having excellent vaccination. And I think the lowest hanging fruit, and for countries like Taiwan and China, etc., the biggest impact was made when they brought in that compulsory birth dose vaccine. And as you correctly pointed out, a country such as ours is only delivering 44% coverage of birth dose. In fact, I must tell you, few months ago, one of our DM students, she wanted to have her child vaccinated, and there was no monovalent vaccine for her to give her child the birth dose. I raised it up in a very important meeting, which involved many people from immunization division as well. And they said, no, vaccine was there even in, definitely in the government sector. We are not sure about the private sector. But what we need to remember is when you think of our population at large, 70% of care is in the private sector, whether we like to hear it or not. And birth dose and the following 3 doses for the baby is something that we can achieve so easily because we vaccinate our kids pretty well when we think of all the other vaccines that children receive. And there's awareness about the fact that a mother has to be screened, and screened from there on, tested for virus loads and be treated is something that many people are completely unaware of. So that comes back to spreading awareness. And I think we may not be front-end clinicians, but we can be all ambassadors for driving that concept through, cross-cutting professionals, for them to know that vaccination and screening every mother. And screening mothers, I just want to add one more comment. WHO talks about an RDT. But, there is a trend in our country right from the HIV days. We grab hold of RDTs that are the cheapest. Mm-hmm. They have to meet a certain standard. I mean, I was recently there to evaluate on behalf of WHO triple elimination of MTCT of HIV, hepatitis B, and syphilis in Maldives. And they use only WHO pre-qualified assays. So, we should spread the importance of quality and going for the lowest hanging fruit, vaccination, to cut our transmission. We have seen cases from, I think this was 3 families from Bihar, where we saw 4 generations of hepatitis B being passed down. We got blood from 3 generations. The first one, we could only know that she had jaundice. So we didn't have a blood sample. But 4 generations of hepatitis being transmitted vertically. And your topic is extremely important for our country. We want to meet the targets coming closer to 2030.
Thank you, ma'am. And as I told, since both of you are there, madam, this viral load testing is also something which we have to move forward. We have to come out of those international companies, although we understand they do come up with good quality, but then the molecular infrastructure which our country has, we need to have more indigenous kits and a more spread out viral load testing facility, because that is again very expensive and a cost prohibitive thing. So that is another place which I think that we also have to start working on so that an appropriate management is done.
I completely agree, because people do have, made in India testing systems, but accompanying that is that, one, the quality of the kit has to be sustained.
Yes.
Reproducibly sustained.
Yes.
And testing personnel cannot cut corners. When you go for a quantitative assay, if they say that there needs to be 3 calibrators or 5 calibrators, you can't get away with 1 or 2 calibrators. So we have to be very stringent in the way we use kits, and the quality has to be sustained. Then I think we have options so that wider testing can be done. Because our country is so huge and so diverse.
Yes.
Yeah, if I can also add up here, I think decentralized testing and these point of care molecular testing devices made in India should be encouraged. That should be our focus. And again, the quality of such tests which are right now available made in India by the companies, they're right now not of that good quality that if we start telling that people to use, then they'll not serve the purpose of identification. Another stigma, not in the pregnant female, ma'am, which we are seeing in our center, and we have a campaign called Empathy for them, is that when you enhance a lot of HbA1c testing in the pregnant female, you land up their in-laws aborting the pregnancy, discriminating them, divorce cases which are coming up. So it is a double-edged sword. We have to also clear the stigma associated with B, that if a girl is positive and is planning a pregnancy and accidentally it is found, then there are a lot of repercussions which we are seeing in females. So this knowledge that it is a treatable, controlled infection is must. Although WHO is focusing on integrating it with the HIV, I have my query and my thoughts on that, because as HIV has become a stigma in the country, B should not be a stigma, and we get so many cases of females being missed. That is why they request the religious not B and C, because they feel that they'll be harassed in case such infections come out to be possible. This social aspect too in our country.
Thank you, sir. Thank you, ma'am. May I now request Professor Agarwal to kindly present a memento as a token of appreciation on behalf of the Institute to Dr. Rahul.
Sir, thank you very much.
Thank you,
This
sir.
token of appreciation from our side. Dr. Abhishek will mail it to you, sir. Thank you.
Thank you, sir.
Thank you for taking a valuable time from your busy schedule, sir. I think you are at PGI today.
I was in IMTech.
Okay.
There was a training on biorepository. We were about to start that, so I forgot this schedule.
Chandigarh.
Yeah.
Oh, right. Thank you, sir. Thank you very much.
Yeah. At the end, I would like to conclude with the vote of thanks. First and foremost, thanks to our director for allowing us this CME, and most importantly, I would like to thank my HOD, Professor Agarwal sir. He is the, he is making a Lagan team. If you would have seen, we are a very, in fact, ours is the youngest AIIMS to come up now, and so this is what we have done from our end. And heartfelt thanks to all our speakers. Ekta ma'am, she is my teacher, my mentor. I had done my PDCC under ma'am, and I had done my PDCC in this hepatic virology. So right from then only, I had a thought in my mind, after I come out from this place, what can we do for the country, in general. So the CME is it is a byproduct of that only. And really, thank you so much, Priya ma'am. Despite your illness, you took up our invitation and you deliberated such a nice talk, and it was really, really, a very learning one. And thank you so much, Rahul sir. Despite your busy schedule, you were there with us, and you actually gave a very enlightening talk on this pregnancy and hepatitis B. Thanks to all our residents, my colleagues, Dr. Mayuri and Dr. Anil, and the ECO platform, and most importantly, all the participants who have joined us, and they were through and through the CME. I hope they would have, taken a lot of learnings from this talk, from the talks of all the stalwarts. They were present with us, and definitely heartfelt thanks to all those mothers, in fact, who are living with this, hepatitis B and C, and they're really not aware. Like just now, Priya ma'am said that 4 generations family from Bihar, they were not aware, and I don't know what, how many generations these patients whom we had tested, either they are knowing or not knowing. And last but not the least, all gratitude of the Almighty. And to our participants, we will be sharing the YouTube recording in our official YouTube channel of AIIMS Rajkot, and we'll also be giving you the certificates very soon. Thank you, everyone. Thank you so much.
Thank you. We can log off.